I'm Harriette Van Spall, Associate Professor of Medicine and Cardiologist from McMaster University, and I'm delighted to have with me at AHA 2023 Professor Mandeep Mehra, who is Principal Investigator of the ARIES HeartMate 3 clinical trial, and we are here to discuss the exciting results of his late-breaking clinical trial. Welcome, Mandeep.
Thank you so much, Harriette. It's such a pleasure to see you again and to have a chance to chat with you.
I am really excited about your trial because it adds to the very small clinical trial space on LVAD therapy in advanced heart failure, and it seeks to answer a very important question related to the morbidity of these devices. Give us some background on the context and the question you were trying to answer.
Yeah, thanks so much, Harriette. First of all, the field of left ventricular assist device therapy continues to evolve in a very, very positive manner. And over the last few decades, and 3 decades to be very honest with you, we have made some strides in improving the type of left ventricular assist devices that are available to us. The most current device available to us is called the HeartMate 3 pump, which is a fully magnetically levitated platform device that actually was designed to reduce hemocompatibility-related adverse events. Hemocompatibility-related adverse events is a term that we denoted several years ago, about 7 years ago, to depict the constellation of complications that we see that are high morbidity complications, including de novo pump thrombosis, which requires pump replacement and a second surgery, strokes, which are often debilitating for these patients, and then bleeding complications, which tend to occur as a very unique construct in these patients that are largely due to angiodysplasias and AV malformations, particularly gastrointestinal bleeding. Now, what has happened over the last few years is with the introduction of this new device, the thrombotic components of hemocompatibility-associated events have reduced dramatically. So we've been able to nearly eliminate pump thrombosis with the new device. We've been able to cut strokes in more than half. And if patients get through the implant hospitalization without a stroke, we almost never see a major return of strokes other than what would ambiently be observed in an advanced heart failure population once they're discharged. But the vexing dilemma in this constellation that we've always had has been with gastrointestinal bleeding or non-surgical bleeds that are mucosal bleedings that occur very uniquely. And it is primarily to address that issue that we embarked on this protocol called the ARIES trial.
Fantastic. So this was a trial that tested the strategy of withdrawing aspirin therapy or withholding aspirin in patients who typically get aspirin plus a vitamin K antagonist. Is that right?
Yeah, that's right. So for 2 decades, Harriette, we have always assumed that aspirin is absolutely critical for use in patients with left ventricular assist device. And why? Well, we think that prior legacy devices, one of which was called the HeartWare device or the HVAD device, was one where we had seen a signal that if aspirin was reduced, that the stroke rates increased in these patients. And so we had always assumed that aspirin is an absolutely critical component of the antithrombotic regimen to use with a left ventricular assist device. Now, with the magnetically levitated pump, the HeartMate 3 pump, where thrombotic events were reduced greatly, we began to ask ourselves the question, is this the right thing? Have we been doing the right thing? And is aspirin being assumed as a positive adjunct to the antithrombotic regimen, but is in fact perhaps as poisonous as it is touted to be in other situations of clinical use?
Right. So somewhat courageous question to ask, despite the evidence from other clinical populations that aspirin may be more risky than beneficial. So tell us the study question or hypothesis rather, and your interesting non-inferiority analytic plan. How did you establish, or how did you decide on a non-inferiority strategy and go about choosing the margin?
Thank you so much for that important question, and the opportunity to actually clarify that. So our question was very simple. Our first question was, do we even need aspirin? And we thought to ourselves that if we can answer that question, that ought to be sufficient as a primary endpoint. Is it safe to avoid aspirin in this group of patients? That was the primary question we were asking. And in order to establish safety, we set aside a primary endpoint that was a combination of hemocompatibility-associated adverse events, which included pump thrombosis, strokes, as well as non-surgical bleeding. Now, we set this trial as a non-inferiority trial, in particular because we weren't sure in which direction the constellation of hemocompatibility-related events would go. And as you correctly pointed out, this was a somewhat courageous question that we were asking in this very unique population. We set the non-inferiority endpoint to be such that the primary median estimate or the primary midpoint estimate would only represent about a 1% difference in the endpoint, such that the tail of the 97.5% confidence limit would be a non-inferiority margin of minus 10%. That's how we achieved that non-inferiority margin. And we basically set aside to power this study with more than a 90% power to answer the question and meet, first of all, the non-inferiority endpoint. We also set a principal secondary endpoint in this trial, which looked at all bleeding events that occurred in these patients. But that was secondary because our first question was, is it safe to take away aspirin? And is it safe enough that the clinical change is at most 1% in the midpoint estimate, with a tail, of course, of a 10% inferiority margin?
Fantastic. And this was a large trial given the patient population, but as you said, it had to be the size to give you the statistical power required to answer the question. Tell us about the number of patients you enrolled and their baseline characteristics.
Yeah, thank you for that. So a few important points about this trial. The first is that this is actually the first ever international randomized controlled trial done with an LVAD. Typically, LVAD trials are done nested within geographic regions like the United States or Canada or Europe. And this was the first one where we went globally. That's point number one. Point number two is that this is also the first ever trial done in the LVAD space that looked at background medical therapy. So these are two very unique constructs of this trial. And in order to do this, we randomized 628 patients to either placebo or to aspirin at a dose of 100 milligrams daily. And the idea then was to look at 12-month outcomes in the two groups based on our non-inferiority endpoint of hemocompatibility-associated adverse events.
Right, and the baseline characteristics?
The baseline characteristics of these patients were very much similar to what we've seen in prior LVAD trials. So one of the most recent large clinical trials in this space, which introduced the pump that we were testing in this, called the HeartMate 3, the fully magnetically levitated LVAD, was called the Momentum 3 trial. And strikingly, the groups are quite similar to the Momentum 3 characteristics at baseline. The average age of patients is about 60 years of age. There were mostly men, and so we were a little short in enrolling women. 22% of the enrolled population were women, but we had 30% of minority patients or Black American patients in this particular trial. What was also unique about the baseline characteristics is that our investigators did not shy away from enrolling patients who would otherwise be thought to be at high thrombotic risk. For example, patients with obesity, patients with diabetes, patients with a prior history of stroke, patients with bypass operations prior to receiving an LVAD, patients with prior vascular events, or even a coronary stent were enrolled in this. So it gave us very high fidelity or precision to look at some subgroups that one would consider as anathema for withdrawal of aspirin or avoidance of aspirin. So these baseline characteristics were quite generalizable and quite important for us to look at, and very similar to what has been enrolled in prior LVAD populations.
And how about the use of medical therapies that could potentially impact your primary endpoints?
Yeah, so because our primary endpoint was one of hemocompatibility, we basically really focused on the antithrombotic regimen here. And the antithrombotic regimen here is either aspirin or no aspirin versus a vitamin K antagonist. And we targeted the vitamin K antagonist population to hit an INR target of 2 to 3. Now, one of the unique features of ARIES is that in order to answer the question of whether what we were observing at the end of the trial was in fact related to the primary question, which is aspirin or no aspirin, we also measured biochemical thromboxane B2 levels in the patients who received placebo or aspirin. And at the same time, this is also the first trial that looked at time in therapeutic range, or TTRs, for the vitamin K antagonist. Previous trials of LVADs have only looked at snapshot times of adequacy of INR, and here we looked at it longitudinally in all patients. So we can be very certain that what we are observing was actually related to the study question. And what I'm pleased to tell you is that the time in therapeutic range was absolutely similar, with no statistical significant difference between the two groups, placebo or aspirin, whereas thromboxane B2 levels were greatly suppressed in those who received even low-dose aspirin, while they were not suppressed at all in placebo. So we know that whatever outcome we found was in fact related to the change we made in the aspirin.
And did you include all of the patients who were randomized in your primary analysis?
Yeah, that's a great question. So we did not, because we induced a blanking period of 2 weeks after the implant to avoid the skew that could have resulted from surgical complications in these patients. So the primary endpoint was set to evaluate events 14 days after the implant was done. However, we pre-specified a number of sensitivity analyses, including evaluating the entire randomized population without the blanking period. We also had the most stringent analysis in this particular trial that included assignment of any patient that was withdrawn or skewed the data to a success in the placebo group and a failure in the aspirin group. And the results were absolutely concordant across the board.
So tell us your primary treatment effect.
Well, the primary treatment effect was a one where we very easily met non-inferiority for the avoidance and exclusion of aspirin as part of the antithrombotic regimen with an LVAD, where we saw, in fact, a much greater success, a 6% absolute success to the time to first event in these patients who were withdrawn from aspirin. in the ARIES trial. This essentially gave us very clear evidence that not only is there no risk of a thrombotic event. In fact, we observed almost no thrombotic events in the pump itself or peripheral arterial embolism. And we saw actually even a signal and a trend to lesser stroke rates in those patients who were withdrawn from the aspirin arm in this trial.
Remarkable and so impactful in terms of what we are going to see in clinical practice following these results. What about your secondary endpoints?
I think the secondary endpoint is perhaps the more important now. Our first point was to establish that it was safe to exclude aspirin as part of an antithrombotic regimen, and we did that. And then our second intention was to look deeper into seeing what happens over time in the entire population with primary and secondary bleeding events or major bleeding events. And these are moderate or severe bleeding events, most of which result in hospitalization, require blood transfusions, and a big health resource utilization. And Harriette, what we found in this trial remarkably was a 34% reduction in major bleeding events in favor of exclusion of aspirin, indicating that just the mere fact of removing this agent is not only safe, but reduces bleeding events greatly in this highly vulnerable population. And what was unique about this was that we also showed a 47% reduction in total days spent in the hospital due to bleeds, as well as a 41% reduction in the cost of care for these patients. Now, in order to calculate cost of care for these patients, we actually looked at it in the US federal payer context, which is Medicare essentially, and we calculated the actual costs to Medicare per hospitalization, and we found that the average cost per hospitalization for non-surgical bleeding in the United States to Medicare was about $13,500, and that this was reduced by 41% in the population that excluded aspirin.
What a remarkable set of results to share with us. Talk to us about the treatment effect on stroke. Can you give us some more details about efficacy in terms of ischemic versus hemorrhagic stroke?
Yeah. Thank you for that important question. What was equally striking for us to look at in this data was we expected that we might see more strokes in patients we excluded aspirin, and we saw the exact opposite. The trend was actually in favor of aspirin. Of course, the correct statistical interpretation of this data is that there was no increase in thrombosis. But when we look at the point estimates, ischemic strokes as well as hemorrhagic strokes all trended to be positive in favor of exclusion of aspirin. We found that initially a bit strange, but then we realized that what was probably happening here is that in patients who often have bleeding events, what one does is one oscillates the antithrombotic regimen between low and high, low and high, low and high in these patients, depending on the kind of events patients have. And we think that just the stabilization of antithrombotic regimens without the invocation of bleeding events may have in fact even had a slightly favorable, although numerical favorable effect alone, even on stroke events. And one of the interesting things is that we found that the 2-year stroke event rate in those patients in whom we exclude aspirin is only about 5%, which actually is the lowest stroke rate we have observed in any LVAD trial.
Now, how generalizable do you think these results are to everyday patients receiving LVAD therapy?
Yeah, so we did a subgroup analysis of these patients and the subgroups, and we found complete consistency, particularly across those patients in whom we, in fact, see either aspirin hyporesponsiveness or more thrombotic risks. So, for example, obese patients, diabetic patients, women in particular. By the way, women have been shown to have greater hemocompatibility-related adverse events and more bleeding with placement of an LVAD, curiously, and we don't quite understand why. And in this trial, the amount of reduction was similar across men and women in the trial, with exclusion of aspirin and no difference by sex in this trial. So interestingly enough, if a patient came into the trial with a history of a prior stroke, they actually benefited even greater on the primary endpoint with the exclusion of aspirin. The same was seen with patients with a prior history of bleeding. So we actually believe, and even in those patients with vascular disease, stents, bypass surgery, we believe that right across the board, we were able to show a consistency in the benefit that suggests to us that this is reasonably generalizable as a result across our populations.
So excluding aspirin from a treatment regimen that has a VKA in patients who had received LVAD therapy for advanced heart failure was non-inferior than a strategy that included aspirin, and in fact was associated with less bleeding and a trend to less stroke. Is that right? With a decrease in healthcare utilization related to these advantages. Is that right?
I think you've summarized that absolutely perfectly, Harriette.
Wonderful. Well, congratulations on a very impactful trial that was executed beautifully with many of our colleagues on your committee and in the writing group. I'm so happy to see your presentation, and I thank you very much for sharing your expertise and your time with us this morning.
Oh, thank you so much for the opportunity to distill these results for your audience and for you.
Congrats again.
Thank you.